Well, good evening, good afternoon. Thank you very much for inviting me for giving this talk. So my talk is 15 minutes, I think, not 5 minutes. So so what I want to do today is give you some updates and also point out that routine pathology may provide a new understanding of disease. Then we'll talk about how ocular pathology combined with molecular omics has revolutionized diagnosis, pathways, prognosis, and treatment, how pathologists are playing a role in that, and ophthalmic pathologists. Briefly talk about artificial intelligence and ocular pathology, and then end with a shout out for all ocular pathologists and oncologists to collaborate and come up with new information in the field of oncology and ocular pathology. So here is a interesting series that I collaborated with folks from LVPAI, and this is a patient or a group of patients with congenital aphakia. And the question the clinicians asked was that if you do a PKP in these patients, all these eyes go into phthisis. And the question was why? And so everybody had stopped doing PKPs for these children with these opacified corneas. And you see how the eye has undergone phthisis. So we were able to give an answer looking at the pathology. So here's a cross-section to the cornea. And what has happened here is because of a developmental defect, the ciliary body and ciliary epithelium is stuck to the posterior corneal surface. So when you do the penetrating graft, you're taking out the secretion of aqueous, and that leads to phthisis. So we were able to answer is because of this anterior segment dysgenesis, you ended up with this clinical problem. So also you can generate new information by routine histopathology when you have a large collection of biopsies available. So, both clinicians and, ocular pathologists are familiar with plexiform and, diffuse and neurofibromatosis. These are the usual types. And we usually look at them as separate entities. But when you have a large collection of these samples, we found in a study a few years ago that not only are they separate tumors, but if you have excisional biopsies or debulking of a plexiform neurofibroma, those can transform into a diffuse form and recurrent forms, and we use histology and IHC to show this. And here you see a case which presented as a plexiform, ended up becoming a diffuse form with only small islands of plexiform tumor left behind. Now moving on to omics and eye pathology. So, studies at the DNA level, the RNA level, and protein level have revolutionized how we function as eye pathologists and interact with the clinicians, where this material is extracted, run through different molecular approaches, and in the end you have marker identification and then including drug target discovery. So here you have a very complicated diagram, and this approach has been used in the eye in diabetic retinopathy, AMD, to discover new medications, and also glaucoma, corneal dystrophies, keratoconus, and myopia. So all these have been studied, these different types of omics, and new therapies have been developed. We, a few years ago again, looked at neurofibromas when I was in the Middle East, and in collaboration with my colleagues at Johns Hopkins at that time, we found that these neurofibromas, if you looked at them using RNA sequencing, you could identify very distinct transcriptional pathways, and we found that these pathways were amenable to some of the new small molecule and antibody type treatments, and they're doing a trial now at Hopkins to validate these results. Now, as all of the pathologists and oncologists probably know this, that we've learned a lot about uveal melanoma through omics, and as we were talking earlier as a group, that pathologists are becoming extinct. Our role has become minimized in these tumors. and we've known that there are new driver mutations for choroidal nevi, and then gene expression profiling, as shown in this slide, has pretty much dramatically changed the way we look at tumors, where you have class 1 tumors, class 2 and class 2 tumors, and the metastatic potential for a class 1 is almost nil. So all you need is a final aspiration biopsy to do this, and you're able to prognosticate this into class 1 and class 2 tumors. And if you add on antibody staining with PRAME, you can also improve the predictability of prognostic accuracies much superior than TNM staining. Why do we need to understand this? Because we do have new pathways available, molecular treatments for treatment of metastatic melanoma. And that's where I come into this slide, this publication from 2021, and then this is from the US, basically showing you that this the tumor is not does not express PD-L1, so does not respond to checkpoint inhibitors, but you still have immune mechanisms in the tumor. So you have this T-cell receptor immune mobilizing antibodies that can be used, which binds to the T cells. And basically, this drug got FDA approval in 2022 for the treatment of non-unresectable metastatic uveal melanoma. This is one of many drugs that are in trials, and this particular drug has shown an improvement in survival by 6 to 8 months compared to, you may think it's not a lot, but this is a first start in the treatment of metastatic melanoma, which was before considered almost non-treatable other than very heroic surgery to resect the liver. Liquid biopsies have also become a very important armamentarium, and this paper by Dr. Jesse Berry, basically in the eye. The concept here is shown nicely on the slide, where you have low tissue tumor availability, and then cell-free DNA, which circulates in the blood. So if you have patients, for example, they have in early stages, the tumor is aggressive, you can find these cell-free DNA, and especially useful in recurrent tumors, and even we know that this is useful in retinoblastoma, as I'll show you in the next slide. So this is the paper that I was talking about. So you can actually find cell-free DNA in the anterior chamber aqueous, and not only it's sticking a needle in the eye with retinoblastoma is not the best thing to do because of the risk of metastasis. So you can actually, from the aqueous, not only identify the RB1 mutations, but also look at copy number variations, which help in identifying prognosis, and also MYC and amplification. And based on just an aqueous humor tap and doing gene sequencing on cell-free DNA, you can really personalize the treatment of retinoblastoma patients. A similar approach has been recently published for uveal melanomas, where you have circulating tumor DNA. You can identify, and these patients who have that are at a high risk of developing metastatic disease. Now, we've also used this omics type approach with a group of collaborators from around the world. Jim Rosenbaum was the main person looking at this, looking at orbital inflammation. And the point that came out of the study was that, it's really, you have common gene signaling pathways in a group of heterogeneous diseases. And the point is that you have drugs available on the market now which can treat these diseases. So this is a drug approved for thyroid eye disease, but this can be used probably for other diseases other than thyroid eye disease. A brief word about AI, and there's not much in eye pathology. We usually know the number of samples are less, but I came across this very interesting study this year. The point is, it's a very busy slide, but basically what these authors did was they looked at low-resolution photographs and processed them by AI, and found that the AI was able to be equivalent to a super-resolution path scanner slide. So you got as good data out of the low resolution by using AI. You can do that. Also, the GPT model is being now, there are models in dermatopathology where it can generate a lot of text and analyze the clinical inputs and also the research papers and pathology reports and give you more informed decision for planning. So there are papers in dermatopathology describing the use of these large language models. So my last slide is basically a pitch for all the ophthalmic pathologists, and we're very fortunate to have a very active group on WhatsApp to share cases. And here you see a large multinational study that was able to validate the WHO classification. I think I make a big pitch here for all Indian ocular pathologists and pathologists to get together. You have huge amounts of data, and this is, I think, going to be a very useful contribution to the field of ophthalmology and ocular oncology. So thank you very much for your attention and for inviting me for this talk. Thank you.